Our first presentation will be by Haitham Awdeh, and Haitham's faculty mentor is April Bailey. And Haitham's project is entitled Preoperative CT Predictors in Determining Prognosis, Survival, and Disease-Free Survival in Ovarian Cancer. Please come, Haitham.
Good afternoon, everybody. So my presentation will be about the preoperative CT predictors in determining prognosis, survival, and disease-free survival in ovarian cancer. So just the most important fact about ovarian cancer is that up to 75% of patients actually present with advanced stage on initial presentation. And the most common type is epithelial cancer, with serous being the most common subtype. For the staging, the only thing that I need to note here is stage 1 and 2 is cancer confined to the ovaries and pelvis, while stage 3 and 4 is peritoneal spread and distant metastasis. So the 5-year survival for the stage 1 will be more than 93%, and it will decline to around 10% or 11% in stage 4. Principles of ovarian cancer surgery. So the purpose of surgery has two roles in ovarian cancer. First, it's the staging of the disease. All ovarian cancers are staged surgically. And the second role is debulking, where the surgeon would aim to leave less than 1 centimeter of residual tumor. And this is considered the best predictor factor in survival. It's important to know that success of surgery depends on the physician's experience, and more importantly on the tumor biology, where more advanced cancer would have less optimal surgery. Chemotherapy followed by surgery is an alternative treatment, although it's not very well established. But this may be important in certain groups who have high surgical morbidity, and selecting these groups would pretty much depend on the imaging features and findings. So I'll go now to the predictive index score. This is a score that has been used to predict the advanced disease and patients unlikely to have optimal surgical reduction. And this score, they score it as presence or absence of certain radiographic findings, and these findings are peritoneal implants more than 2 centimeters, diffuse peritoneal thickening, bowel mesentery involvement, whether it's small bowel or large bowel mesentery involvement, omental extension to the lesser sac with involvement of the stomach or spleen, suprarenal para-aortic adenopathy more than 1 centimeter, ascites at all CT cuts, liver lesions or liver deposits, so any intraparenchymal liver lesion of any size, and liver deposit or liver surface deposit more than 2 centimeters. And lastly, it's portohepatitis or gallbladder fossa disease. So in our study, we evaluate the pre-treatment significance of each of these markers on survival and disease-free survival. So the methods. This is the retrospective study between 2008 and 2012. All patients had advanced ovarian cancer with the intent of performing maximal cytotoxic reduction surgery. So all patients had chemotherapy after surgery, and the CT scan was performed within 60 days from the day of surgery. Data were collected by a single radiologist without knowledge of treatment outcome, and univariate and multivariate survival analysis were performed using Cox proportional hazard survival model. So we had a total of 142 records, and it's important to know that here that 20% of our patients had no CT evidence of extra-ovarian disease, although they were advanced stage cancer. For the results, we see that peritoneal implants or peritoneal disease was the most common feature in these patients. More than 60% of patients had peritoneal disease, and omental extension was present in more than 50% of patients. When we looked at the overall survival and disease recurrence in these patients, we see that patients who had predictor score of 0 had survival rate of 93%, as compared to 25% in patients who had a score of 9. And then when you look at the recurrence rate, you see that these patients had 21% recurrence rate. Now, when we look at the predictors of 1 to 6, we see that the overall survival was pretty much comparable between 55 to 65%. For the recurrence rate on these patients, we see that patients with at least one predictor, the recurrence rate was pretty high, up to 70%, and the recurrence rate between 1 and 9 were pretty much comparable. So for predicting optimal versus suboptimal surgery, we see that patients with 0 predictors had 90% chance of surgical success, while patients with 9 predictors had 25% of surgical success or optimal surgery. So prior reports say a high predictive index can preclude surgeon from surgical exploration. Now, just as an observation, despite the high score of some of the patients, the optimal debulking surgery was performed or has been adequate with a comparable survival rate. And then again, for the recurrence, patients with at least one predictor had high recurrence rate. For the survival model, we used the Cox proportional survival model. On the univariate analysis, we looked at all the predictors, and we can see that peritoneal disease and bowel mesentery involvement were significant or had significant impact on survival and disease-free survival. Omental extension and suprarenal para-aortic adenopathy had significant impact on the disease-free survival. And portal hepatitis disease had impact on the survival. For the ascites, although we had 45% of our patients at ascites, it didn't show that it showed any significant impact on either survival or disease-free survival. For the liver lesions, this may be a fake out. Well, it's not significant, but this may be a fake out because only 10% of our patients had liver lesions. So for the overall survival, the model predicts that bowel mesentery involvement and portal hepatitis disease had the lowest survival rates at 1, 3, and 5 years. When we look at the sum of the predictors, we see that the model predicts patients with 0 predictors would have at least 70% or more than 70% chance of overall survival in 5 years. That will drop to less than 30% in patients with 9 predictors. For the recurrence-free survival, the model predicts that most of the patients would have disease in 5 years. And it shows that the bowel mesentery involvement and the omental extension to the stomach or lesser sac have the lowest or have the worst recurrence rate. When you look at the sum of the predictors, patients with number of 0 or score of 0, 39% of these patients will be disease-free in 5 years. That would drop to 10% with a score of 4 and almost 0% with a score of 9. So we also looked at the multivariate survival analysis, and the model selected the algorithm selects the bowel mesentery as the best model fit for the overall survival in these patients, as shown on this curve. And then the model also selects the omental extension as the best fit for the recurrence-free survival. However, so this is the omental extension survival, disease-free survival curve. However, when this was taken out of the equation, the model selected the bowel mesentery involvement, actually. And when you look at these two curves, they look pretty much the same. So, as a conclusion, CT predictors in preoperative assessment of ovarian cancer can be used in determining not only the likelihood of a successful debulking surgery, but also mortality and disease-free survival, with bowel mesentery being the single best predictor of both survival and disease-free survival. In general, radiologists do describe these findings in their reports. However, when a patient has extensive disease, it's not uncommon for the radiologist to lump up all the findings as diffuse intraperitoneal disease or extensive intraperitoneal disease. And I think this is the place, or this is the area where we should provide more details, especially in patients with more advanced disease. Thank you. Sure.
What did you use as the visual for a mesenteric involvement?
It should be a plaque or a lesion along the mesentery, either small bowel or large bowel.
Okay, so the people at Sloan Kettering use multiple small nodules along the mesenteric rays. Was that included or no?
So any mesenteric involvement that can be measured has been inserted.
Okay.
If the mesenteric nodule is tiny or suspicious, it wasn't included in the measurements.
I want to follow up on Dr. Fielding's question. How did you distinguish mesenteric involvement from peritoneal lining involvement? In other words, did it have to invade the mesentery for you to call it mesenteric?
So this is a good question. Actually, sometimes it's not, we cannot differentiate between mesenteric and peritoneal. So in these patients where the lesion or the involvement is suspected to be in both peritoneal and mesenteric, the score will be actually twice. So we will calculate the mesenteric involvement and the peritoneal involvement. It's sometimes difficult to say if this is only peritoneal versus extending to the mesentery. That's how I did it, or that's how we measured it.
The multivariate analysis that you did, you included 10 covariates.
Correct.
And you were looking at 2 outcome parameters. How did and you said this is the most significant factor, the ball.
This is the best.
So is any other factor that was significant?
I didn't get what?
Any other factor? What I'm asking is, when you do the multivariate analysis, it gives you what's the significance of each factor in context of all of the factors included in the model.
Correct.
So this is the only factor that became significant?
Yeah, so sometimes the multivariate analysis would give you one or more graphs. In our analysis, the algorithm itself gave us only one graph, so it showed that the mental disease or mental extension and the bowel mesentery involvement were the most significant in both overall survival and disease-free survival. The algorithm itself just selected one variable rather than more than one. That's how the algorithm works.
Do you have the hazard ratios and the p-values in the table?
I don't have them in the presentation, but we do have the hazard ratios and the p-values, yeah.
Okay, thanks.
Thank you very much.
Thank you.